Well, thank you. It is really my honor to speak in the presence of people who are true luminaries in this field. And I really got interested in the whole, I've been interested in the SI joint my whole career, but when I spent some time a couple of years ago at Sendai with Dr. Kurosawa and Dr. Murakami, it really stimulated my interest. And over the past couple of years, it's been great. Can you hear me okay back there? So anyway, I'm just going to give you how I go about treating it, and it's not quite as it's science-based in the sense that I go through and I try to get the literature out of all the maneuvers, but this is my basic pathway. And I think that the first thing to know is my patient population may be a little bit different. So I'm in a children's hospital. We do see adults, but we're seeing kids and young adults. Some older adults too, because we in sports medicine see that, and there's a lot of Ehlers-Danlos patients that are in the mix there, particularly some of the younger Ehlers-Danlos, but we're getting some of the older ones as well, and they certainly are difficult to work with. And as you know, it's kind of confusing many times because you've got a lot of this radiating pain, and you're not sure where it's coming from, as we've seen several times over the past day with Dr. Murakami's study. But this was a case I thought was sort of interesting. Where does that go to? All right, so this is going faster than I thought. So this 45-year-old male landscaper that came to me from one of our hip surgeons, one of our really good hip surgeons, and basically he had an L4-5S1 fusion. I'm sorry, just an L4-5 fusion. About a couple of years before that, and he woke up from the table and immediately had this tremendous amount of pain, mostly around the anterior lateral portion of the hip, was quite debilitated from it, ended up with a lot of imaging, and he then saw the hip surgeon, and of course he did have a labral tear, FAI, and very positive impingement signs, and so he had surgery on the hip, but the pain was still there. And so he came into my office, and he just had a very antalgic gait coming down the hallway there, and pretty strong psoas signs on that side. He was not tender on the SI joint, or maybe minimally tender, but really nothing much was there. But he had some signs. His thigh thrust was minimally positive. Most of it was still with that hip internal rotation that was actually causing his pain. And I thought, well, maybe he had some more chondral loss in the hip joint itself. And then I did my basic hip SI evaluation, and he had a sort of a high sacral sulcus on the right side, PSIS, and very low on the right side in the front at the ASIS. And so he was really miserable coming down the hall, so I just did one of the maneuvers where I actually just used his hamstring to help rotate it back, and then I did a sort of a gentle maneuver where I kind of rotated the pelvis when he was in the decubitus position, and like 95% of his pain went away. He stood up and he was just as happy as could be. Came back about 6 weeks later. I ended up doing an SI joint injection to quiet it down again, and he's doing very well at this point in time. And so I thought that was kind of an interesting finding. So really there's, thinking about the history, you have to think about the instabilities, what's going on. I won't go through all that because you all know that. But in our population, I really see a lot of young kids, and they have a lot of non-specific low back pain. And by one study that was recently done, it looks like maybe somewhere around 30% of them, as well as the adult population, have some SI instability. God, what am I doing? I am somehow hitting this wrong. Here we go. So some of the things that you consider in kids, young adults, and thinking about their sports biomechanics, because invariably it's something involved with that, where we see it very commonly in basketball players, jumpers, and running is probably one of the bigger things. And Kristen Whitney and myself a couple of years ago published an article showing that SI pain in that young athlete was related to some dorsiflex foot and an overstride. And with that overstride pattern, you're getting higher forces that you can actually measure that go up the leg, And you're also getting a hip drop on the contralateral side, which we think is what the basics of that is. Also, during growth, you have an increased pelvic incident because the pelvis rolls forward, and that may add to some of that pain during or instability during that growth period. Ligamentous laxity, because the Ehlers-Danlos is an issue. And then we always sort of keep an eye out for inflammatory disease, which in all age groups. And I won't go through the physical exam much more than to say I look at the Beighton score, and I do that osteopathic examination, trying to look for sacral rotation as well as ilium innominate types of rotations as well. And I also evaluate their sport. So we'll oftentimes, if they're a runner, do a gait analysis looking for impact peaks. And as you can see on the left lower side there, that young lady has in her overstride is actually getting a contralateral hip drop. And when you correct the stride length, you often can decrease the hip drop on that side, decrease the pressure going up the leg, but taking away that impact peak on the far side of that graft. And they'll land in a much smoother manner, and that will oftentimes take care of their problems. In terms of imaging, I don't do a lot of imaging except up front. If they've had persistent pain for more than 6 or 8 weeks, I'll typically get a standing AP pelvis, done views, and false profile views, looking for any kind of issue. And this is a girl I presented yesterday as well, but this is a girl I just saw this past Friday who has had a couple of years of low back pain, it was initially hip pain, and then it became low back pain, and then when I saw her on Friday, it was coming back as more hip pain, which I thought was psoas. Her original x-rays didn't show too much, although that's not a perfect x-ray. It's a supine film, so I went ahead and ordered a standing upright film. And you could see that she's got some DDH right there, although her anterior center edge ankle isn't too bad. So we'll see what the hip folks say on that one. So that's some of the imaging that I'll usually go with. If there's any sign of or concern about SI inflammation, you can look for the grading of that, as you can see right here, which is standard grading with when you first get some sclerosis and small erosions, and then you get some widening of the joint, and then finally you'll end up with some ankylosis of the joint, which may give you some clues. The MRI is probably the only other test that I'll usually end up getting, which is, pardon me one second. Sorry about that. I got called 3 times in the middle of the night last night because people don't know that I'm on the other side. So anyway, and you get the MRIs, and the newer MRIs particularly will show about that. Will have, you get the T1 signals, which is on the left there, which you can actually see any of the structural damages that's actually occurring to the bony side of it, and you'll see marrow replacement with fatty replacement. And you want to get the stir image, which is the one on the right, to look for inflammation in the joint. And you can see here, this is another T1 signal that shows much more marrow change, which goes along with that inflammation, erosions, and you're starting to see widening of that joint. 2 new signals that have been looked at are the 3D vibe, where you can really, without going to the bone images, actually can see most of that cortical erosion pretty well. So most of your good MRIs right now will do that. And then recently, we just started this at our hospital, where we look at the synthetic CT scan, which basically gives you the CT scan effect, and you can look very nicely at any of those small cortical irregularities that are occurring. And then with the SI joint, we need to consider any kind of variations. And one of the things that we see with sports, particularly with running and jumping sports, is osteitis condensans, which might make you think that it's an inflammatory problem, but it's the way you can tell the difference is as you scroll back and forth, there's a localized capsular inflammation that occurs at the SI joint that you don't see through the whole depth of the joint, and so that's actually not all that terribly uncommon. And the other thing that's recently been looked at by the Gans group in Berlin has defined, using that synthetic CT scan, quite a variety of anatomic changes that can actually occur there. And they found that something like 82% of these were present in the patient population that had bad SI joint pain versus only about 19% in the groups that were normal with no SI pain at all. So an interesting finding. And then there was just a SPECT bone scan, which I don't really use very often, but it's a nice tool to know that's in your belt. That was a study that was done with Jenny Saunders, and she did over 1,200 patients and showed that, particularly that SPECT part, could show the enthesitis that was occurring at in the ligamentous component of it. And then when I get to my treatment, basically I put these up on the right here just a little bit ago because I wanted to get the comments from the physical therapist. But basically, I go through the phases of isometric phase first, getting them moving, try to get them out of sports. Can't always get them out of sports, but try to do that. And then we move to phase 2, where we start the more dynamic phases. And what I usually give them in their take-home sheets, we have electronic sheets that go along with their chart, and they can get it through their portal. These basic exercises, and at the top I start with doing bridges with a belt around their, just above their knees, and do several sets of those. Obviously, starting with a low volume of those and going up slowly. I think the key on all these is doing them slowly. And then I do the 3 abdominal exercises, which are the ones in the middle there, with the holding your umbilicus and pulling it toward your abdomen, toward your spine. And then I do the legs with more of the bicycle motion, keeping the back flat against the bed for the more sagittal plane abdominals. Then you have them go side to side slowly, and it has to be slowly for the obliques. And then the only thing more after they've done those in the supine position is to do some sort of extension. But again, the extension has to be slow because they may have a little facet joint problem. So I usually get a Swiss ball or have them just do Superman. And because the multifidi is evidence-based as one of the more important ones for stabilization. And a lot of myotherapy will go on initially if there's a lot of spasm, quadratus, et cetera. And then get them back to their sports, gradually doing functional drills, paying attention to what's been mentioned earlier today, with almost that's that tensegrity, where everything is kind of attached and sort of compression. So you may have something further down in the hamstring that's actually affecting things that are coming up into the SI joint. And the SI belt, as Dr. Kurosawa has brought up. And then as far as mobilization goes, I'll do a little bit of it once or twice. I don't sell myself as an osteopath, but I sometimes will do it gently to get them moving on it. Most of the time I can give them some exercises that they can kind of reset it themselves, but if not, I'll send them to someone who will actually go do that. I might use ENSAs up front. Now, injections, there's quite a variety of injections, and how do I make my decision to do that? Well, I try to do everything conservative first without getting too aggressive, but I basically have 3 criteria when I want to start an injection, like with ropivacaine and cortisone or Toradol. And my 3 indications are if they have too much pain to do their exercises. Number 2 is if they've been doing them really great and they just can't quite break that plateau. Sometimes I can help them break that plateau. And the 3rd reason is if it's the Super Bowl. So, so basically, and then where do you inject? Well, I typically will do both the ligaments and the intra-articular, but I'm doing it under ultrasound, so I'll get to the accuracy of that, but can be up as high as about 88%, not quite as high as a fluoroscopy, but I'll aim my needle both into the ligaments and then without coming out of the skin, aim it down toward the lower end of that SI joint. And then many times, and particularly not so much in kids, but in that older population starting around 30 to 40, I'll get people with EDS, unstable joints, and not only do they have a lot of SI pain, but they have piriformis, and they have a lot of the cluneal nerves, may have piriformis syndrome. And so I'll be using just like a buffered D5W or a saline solution around the nerves, doing hydrodissection at the same time that I'm actually doing some of the SI work. But the initial injections are usually an anesthetic and cortisone, or if I'm with the EDS population, because they have a lot of literature on their websites about the negativity of cortisone, I'll use Toradol if there's no contraindication for that. And then I'll get to PRP and prolotherapy possibly after that. So as Dr. Murakami had showed, most of your pain is coming from the periarticular region. So and there was a study that was actually done recently by Tantaway where he actually looked at patients that got, compared the two, cortisone and a numbing agent into the joint versus into the joint and into the ligaments, and found there was significant improvement by doing both of them at the same time. And that was just published last year, which I thought was kind of interesting. And so that's led me to sort of think about, that's what I've been gravitating. Well, I don't do that all the time, but I'd say it's helpful because I do think there's some diagnostic value, not so much about the SI joint, but if you can knock out all the pain by doing those two injections and you're not sure if it's the hip or the back, I think that sometimes can help you. But as you can see there, if you're on the left-hand ultrasound, you've got the lower end of the SI joint where you've got the probe down more at that inferior aspect of it. And then if you take the probe up higher, right near the PSIS and the S2 neuroforamina, you get into more of that ligamentous component of it. And so with one needle stick, usually, sometimes I have to do it twice, I can actually hit both of those spots to inject. Whether I'm injecting an anesthetic, also if I'm going to be using PRP or something, I can do that. In terms of the accuracy of fluoro versus ultrasound, most studies would say that the fluoro was a bit more accurate, but it's probably operator dependent for the ultrasound, as well as probably for the fluoroscopy. And but it's not tremendous difference, like 87 versus 92%. So I'm not doing the surgery, so I can buy that. I think for the surgeons who are doing it, you're going to probably want to do the fluoroscopic component of it. From a treatment standpoint, there's probably not much of a difference whether you're doing one or the other, as been shown by a couple of studies. And the other value of ultrasound that I find is it's somewhat diagnostic for where your muscle weakness is. So when you put that probe on, over on the left-hand side there, you see nice, robust multifidi erector-spinae muscles, and what I call the M sign, versus more of the, if you get down into the W sign where they're drooping down. But in that middle slide, you can see a lot of fatty atrophy of the multifidi right around the spinous processes there. And then I just threw that other one in on the right-hand side because some of the rheumatologists will do Doppler flow on that to look for signs of inflammation that might tip you off towards some inflammatory problem going on. And then nerve entrapment really confuses the issue many times. The superior cluneal nerve is probably the most common one, L1, L2, and L3, and the L3 comes right through a fibroosseous tunnel right in this location here, and you can actually palpate that when it gets inflamed. You can kind of roll your fingers over it, and that can be a significant issue. So if you have your probe up on the iliac crest, you can look for that. And as you can see, as I kind of rolling that probe up, you'll find that fibroosseous tunnel with that nerve coming into it right about there. So that's the L3, superior cleneal nerve, coming through there. And then I'll usually turn the probe 90 degrees and come sagittal plane right into it, in plane with the probe, which can be useful. Middle cleneal nerve it's probably not as common, although that's not clear. But it can be very confusing with SI joint pain itself because it is right there giving the same innervation pattern of it. So when you're doing your compression tests and things like that, maybe you're just pushing on the cleneal nerves. And they've been shown to go over the top, through, and underneath the long SI ligament. So sometimes what I'll do is actually inject that area alone, isolated, if I think that's what may be going on, or in combination with everything else that I'm doing at that time. And if I'm doing the nerve injections, I'll commonly use just a buffered D5W with a tiny bit of cortisone. Like I'll put a syringe of 9.5 cc's of buffered D5W, and then I'll put 2 milligrams of triamcinolone, which is almost nothing, but because I don't want to badly affect the nerves with the cortisone, which if you do repetitively could be a problem. And so some of the orthobiologics now, if you have someone with hypermobility in my population, because there's a lot of younger kids, now you might start talking about doing prolotherapy, which could be PRP, or it could be, I use polydocanol, or many times I still use dextrose as well. Polydocanol was based on the work that was done by Fraser Burling out in New Zealand, and he showed it effective in a number of locations. And I've had really good effects with it when I've been stabilizing EDS shoulders. I'm not talking about traumatic dislocated shoulders, but with EDS that have had multiple dislocations or subluxations. We were doing a prospective study now, but we had a nice retrospective study showing that we stabilized it pretty nicely. But Jenny Saunders did a study where she had basically 100% effectiveness with PRP. So I'm not sure. I think these are the things that we have to kind of work out. The key is to get your needle into the deep interosseous ligaments for the most part, but then I always come down and look at the other ligaments, particularly, postpartal women will have a lot of involvement of the sacrotuberous ligament, and sometimes you'll have iliolumbar ligament involved. So you have to really do a good job palpating and sort of figuring out where your major deficits are. There was one study by Kim that showed the dextrose given twice. What am I doing? Was pretty effective and compared against cortisone. Now, we did a small study looking at our Ehlers-Danlos, which is just about to get published, but we're going to start a big prospective study, which is in the IRB now. And we looked at PRP, polydocanol, and tetradecyl sulfate. The polydocanol and tetradecyl are for vein sclerosing, and basically had a total of 14 joints in 10 patients that were actually injected, and it was mostly into the deep SI, but again, it was based on where their ligamentous tenderness was. Had pretty good decrease in their visual analog scales, good amount. There weren't a lot of athletes in the Ehlers-Danlos population, but they were back to more athletic activity, and reasonably good patient satisfaction from that. And again, just more of the data on that. So I think it's an interesting area. I think it needs a lot more studies, even animal studies, I think, to look at what's actually happening with the Ehlers-Danlos ligaments, and whether you can do something to change the structure of that, or at least thicken it and make it more tolerable. So I think that was, one other thing I wanted to add into this was shockwave. So we do a lot of shockwave in our practice. I used to do a lot of PRP and tendons and everything, and it's taken away at least half, maybe 2/3 of our volume of PRP injections into tendons, because the first line of care in our institution has become really just using extracorporeal shockwave therapy. And I recently started doing it on SI joints, and one was based on this study here, published in 24, that did look at a significant decrease in pain. So, you know, there may be some value to doing PRP and then following that with shockwave therapy up and down, which is a simple thing. There's no downtime to it. It's a little uncomfortable getting it done, but I've had it done on both my Achilles, both my hamstrings, one SI joint. And it actually is a fairly effective tool. And so that's kind of our approach.
What if you could just spend 1 minute talking about the theory of the polydocanol and the dextrose versus like PRP when you're injecting the ligamentous complex in the back, and the theory of action. I get the PRP anti-inflammatory effects, but the other two substances create.
So that's a great question, and I'm not sure of the answer, but the theory is, and I was just talking to Jeff Donner about this earlier, is that my worry initially was if you're using PRP, you're just stimulating regrowth of the abnormal collagen fibers. So maybe you're not doing anything good, but the data doesn't seem to support that.
Yeah.
If you're using polydocanol or dextrose or tetradecyl, you're trying to stimulate scar tissue, and the scar tissue may be thicker, perhaps a different type of tissue, and that's at least my thought.
Very good. All right. Thank you, Pierre.
Applause. We're helping.